Okay, well let's move on to the next topic, and that's multifocal performance. Okay, you touched on this before. What I want to do is get a little more in depth, and this is where we can get into, if you want to, a little more on the fees as far as specialty fitting. But basically, chair time. You mentioned chair time in your office. It'd be interesting to see what others have to say about this. When to dispense these lenses. Do you do that on day one? Do you do it later on? When to bring the patient back for post-fitting visits? And typically, how many of those does it take? How many lenses do you find that it takes in order to make a patient happy, based, again, maybe on whether it's an emerging presbyope or whether it's a full presbyope? And then when do you really consider what you've done to be a successful fit?
I also have a practice that runs highly on my ancillary staff. And I have highly trained ancillary staff. And I find that my presbyopic ancillary staff are probably some of the better people to work with my presbyopic patients, because the patient just feels like they get it. My primary role is to go in and talk and hear the patient and understand where that patient's coming from, and then choose a lens from that point on. I think patients really need to be heard. And it may be for the 18th time that day that I've had somebody explain to me what presbyopia is and how that's affecting their life, but if a patient doesn't get that out, you'll have less success with the lens. I need that conversation is something that's been honed over time for me, so it becomes shorter and shorter. But the patient really has a driving need for me to understand that they are having problems, if they're truly at the presbyopic level. And but then my staff really does, honestly, my staff does most of the work. I have a fabulous group of people I work with, but they're applying the lenses, taking them on and off. I'm in with other patients, and I pop back into the patient and kind of do some adjustments and move on with that. And for me, that is the best use of my time.
But the question that you ask the patient is, how are you seeing when they have the lens in? It's not read this chart or this, how are you seeing? And you're hoping to hear that, good, great. You want to hear that, at least with the lens on, they already feel naturally that they're getting some decent vision out of that. Because that already lets you know that you're a good part of the way there to making them a successful fitter. If you have that patient's had the lens even for 5 minutes on and they're like, what the heck, what's going on? You know that you're probably right. There's going to be that 15% unless you messed up or your technician's transposed a number or something like that. Right. But if you have that patient says, great, you already know you're on your way to a path of success.
Well, let's take it to the next point, and that is that okay, you're doing this on a fairly consistent basis now with most of your patients that are in the presbyopic category. You know that if you've had any history with multifocal lenses over the years, that there were times when your success rate was maybe 2 out of 10. It might work, and 8 out of 10 it didn't. Now we're into different times. What would you consider your current multifocal success rate versus 10 years ago, let's say?
I was 85%.
I'm in that realm, yeah.
Yep, that's right about that.
Agree? Okay.
Yeah.
And
John, can I touch on one thing?
Absolutely.
That I do things a little bit more simplified than you guys, and maybe it's because I'm not quite as smart, but I have a couple requirements for my patients when they leave the office. Is number one, they need to be able to see to drive, and they need to be able to see their cell phone. And if they can do those two things, I know they're going to come back. And the requirements are make sure the patient can see in the distance, because if you can't see in the distance, they're going to come back with the lenses in their hand and hand them to you. And so that's an absolute requirement, and we can enhance that. But for me, I'm not as tied up into the initial visit. I want to make sure the patient gets good vision, they can go out and they can start seeing things in their normal everyday. But the most important visit to me is the second visit. And that's really where I feel that I can fine-tune things, because now the lenses has been on their eyes for several hours, and we can fine-tune it because
and they have experience in their own environment.
Yeah,
I tell my patients my office environment is only a normal environment for me.
And I think there's something to that. I think that there is always going to be multiple ways to arrive at the same destination, and there are certain patients that I go this direction and do everything. There are certain patients, like I said, as soon as they say the word great, I'm like, all right, see you next week.
Yeah.
Okay?
One
See,
of the
I
other things we
disagree
have
with
to
that
keep
philosophy.
in mind is
No.
making sure we check binocular acuities, and that's something that I oftentimes, I'll walk into a room and my techs are covering one of the patient's eyes, and I'm like, no, don't do that. Let's work on binocular acuity. Let's make sure the patient is happy with their vision.
And you tell the patient to quit.
Yeah, and
quit
don't do the
covering one eye or the
contact
other?
lens salute. That's right.
No, no,
So
no,
to speak.
No, 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 no.
I
I'm
just
not saying
wanna know.
modified- I'm
no,
not
I just want
saying
to know
you're-
which eye is dominant. I want my staff. Remember, my text, when I say eye, I'm like Chris. I see a patient at the beginning, I see him in the middle, I see him at the end. I do very little. Our technicians are doing 95% of this work, including sometimes choosing the lenses completely. So, but I want them to know within a quarter diopter each time they come, especially visit two, where they are both unilateral and binocular, because I want that all in the record so that if I have to shift a little bit here and there, I that's where I come in. Okay, how do I want to shift this? Do I want to add plus to distance? Do I want to make a change to bifocal add?
Doing monocular visual acuities is certainly something we want on our record, but we don't want patients
Fixated on.
fixating
Right.
on that before we walk in the room to talk to them. And I'm like the two of you. I don't know where Steve is, but I like to have as little interaction other than discussing with the patient as I can, and our techs do that. But I want to make sure I guard when they do what they do.
Right.
And let's not have the contact lenses go on and start covering eyes.
Oh,
Let's
right.
let them
I
settle.
will
Let's let
use-
the patient experience their distance vision binocularly, experience their vision near binocularly, and then move from there.